Problems can occur with the fetus's presentation or position during labor and delivery. Although most fetuses move in the proper birthing position, alternative positions and presentations can occur, making vaginal delivery difficult and, in some cases, impossible.
So, fetal malpresentation. Fetal malpresentation refers to the fetal presenting part other than vertex and includes breech, transverse, base, brow, and sinciput. Malpresentations may be identified late in pregnancy or may not be discovered until the initial assessment during the labor. So there are three types of fetal malpresentation. First is breech presentation, second is vertex presentation, and third is brow presentation. Breech presentation means that either the buttocks or the feet are the first body parts that will come in contact with the cervix. It occurs in approximately 3% of the birth and are affected by fetal attitude. Its presentation can be difficult births, with the presenting point influencing the degree of difficulty. Breech presentation. So first is complete flex. The baby's hips and the knees are flexed so that the body is sitting cross-legged with feet beside the bottom. So the second is footing, or one or both feet come first with the bottom at a higher position. This is a rare term but relatively common with premature fetuses. So third is frank extended. The baby bottom comes first and the legs are flexed at the hip and extended at the knees. With feet near the ears, 65 to 70% of breech baby are in the frank breech presentation. So, management. If the woman is in early labor, the membranes are intact, attempt external cephalic version to cholytics such as terbutaline 0.25 mg IM can be used before ECV to help relax the uterus. If ECV is successful, proceed with normal childbirth. If ECV feels not too advisable, delivery can cesarean section. Attempt external version if breech presentation is present at or 37 weeks. Before 37 weeks, a successful version is more likely spontaneously revert back to breech presentation. Second is the vaginal delivery is possible. And third is membranes are intact and amniotic fluid is adequate. Third is there is no complication. Vaginal breech delivery is safe and feasible under the following conditions. So first is complete or frank breech. Second is adequate clinical pelvimetry. Third is fetus is not too large. Fourth is no previous cesarean section for the fallopian pelvic disproportion rather. And then fifth is flexed head. So cesarean section is recommended in cases of first double footing breech, second is small or malformed pelvis, third is very large fetus, fourth is previous cesarean section for cephalopelvic disproportion, fifth is hyperextended or deflexed head.
For the vertex presentation, we have chin anterior position and chin posterior position. In the chin anterior position, if the cervix is fully dilated, allow to proceed with normal childbirth. If there is progress and no signs of obstruction, augment labor with oxytocin. If descent is unsatisfactory, deliver by forceps. If cervix is not fully dilated and there is no sign of obstruction, augment labor with oxytocin. For the chin posterior position, if the cervix is fully dilated, deliver by cesarean section. If the cervix is not fully dilated, monitor descent, rotation, and progress. If there are signs of obstruction, deliver by cesarean section. Do not perform vacuum extraction for face presentation.
Management. In the chin anterior position, prolonged labor is common. Descent and delivery of the head by flexion may occur. In the chin posterior, however, the fully extended head is blocked by the sacrum. This prevents descent and labor is arrested. Transverse presentation. It is when the fetus lies horizontally in the pelvis so that the longest fetal axis is perpendicular to the mother. The presenting part is usually one of the shoulders or the acromion, process, an iliac crest, and an elbow. Next is the syncypal presentation. It is the larger diameter of the fetal head is presented. Label for progress is loaded and with his lower descent of the fetal head. And the face presentation. The face presentation is caused by hyperextension of the fetal head so that neither that occiput nor the sinciput is palpable on vaginal examination. The management is if the fetus is alive or dead, deliver it via cesarean section, and do not deliver brow presentation by vacuum extraction. The risks are longer labor caused by ineffective contractions and slow or arrested fetal descent, dysfunctional functionally labor pattern, cesarean birth if brow presentation persists or if the fetus is large, fetal risk, mortality because of cerebral and neck compression, and damage to the trachea and larynx.
Nursing care of client with malpresentation. Observe closely for abnormal labor patterns. Monitor fetal heartbeat and contractions continuously. Anticipate forceps-assisted birth. Anticipating cesarean birth for incomplete breech or shoulder presentation. Be prepared for childbirth emergencies such as the cesarean section, forceps-assisted delivery, and neonatal resuscitation. Position patient in Trendelenburg or Nietzsche's position. Manually raise the presenting part aseptically.
Fetal malposition. It refers to positions other than occipito-anterior position. Malpositions include occipito-posterior and occipito-transverse positions of fetal head in relation to maternal pelvis. It is usually seen in multipara or those with lax abdominal wall. Fetal malpositions are assessed during labor, and there are two types of fetal malposition: the occipito-posterior position and the occipito-transverse position. Types of malposition. First is the occipito-posterior position. It is arrested labor may occur when the head does not rotate and or descend. Delivery may be complicated by perineal tears or extension of an episiotomy.
For management, it may be done through infusing of oxytocin, where clinical pelvimetry should be attempted. If no gross pelvic contraction is documented and uterine contractions are inadequate, cautious infusion of oxytocin may be tried. Mode of delivery may be done depending on the clinical findings. The following modes of delivery are available, such as spontaneous vaginal delivery, outlet forceps delivery of a direct occipital posterior presentation, manual rotation to the occipital anterior position, followed by spontaneous or out forceps delivery. misfire rotation and extraction, vacuum extraction for rotation extraction, or both, and cesarean section. The second type of malposition is the occipitotransverse position. It is the incomplete rotation of the OP to OA, results in the fetal head being in the horizontal or transverse position. It is when the fetal head engages but for various reasons does not rotate spontaneously in the mid-pelvis as in normal labor. Mid-pelvic transverse arrest is diagnosed. Occasionally, it occurs at the inlet, molding and caput succedaneum formation, falsely indicating a lower descent. In this type of malposition, cesarean section is required. Let us discuss fetal macrosomia, also known as the excessive fetal size. Macrosomia implies growth beyond a certain size, usually 4,000 to 4,500 grams, regardless of gestational age. It occurs in about 5% of the delivery. Its risk factors are excessive maternal weight gain, which is greater than 20 kilograms, post-date pregnancy. Previous delivery of a macrosomic infant, however, less than 40% of macrosomic infants are born to patients with identifiable risk factors. Next is the shoulder dystocia. While morbidity to infant and mother increases with increasing size between 4,000 and 4,500 grams, perinatal mortality for fetuses weighing more than 4,500 grams is about 5-fold higher than in normal term infants. An incidence of shoulder dystocia in this group is at least 10%. For the shoulder dystocia drill, first is call for help. Next, generous episiotomy. Third, suprapubic pressure, simply only one assistant while normal downward traction. Next is the McRoberts maneuver, where there are two assistants, resolved most case, and if it fails, next step may be attempted the wood screw maneuver. Next is the attempted posterior arm delivery, and lastly the other techniques like the Zavanelli maneuver and the fracture of anterior clavicle, which is the humerus.
Management. Fetal abdominal dystocia at 28 weeks caused by immensely distended bladder. Delivery was made possible by expression of fluid from the bladder through perforation at umbilicus. Median sagittal section shows interior of bladder and compression of organs of abdominal and thoracic cavities. A black thread has been laid in the urethra. Management is determined by the severity of the disorder and its prognosis. Fetal malformation. Fetal malformation may cause dystocia primarily through feto-pelvic disproportion. Fetal anomalies. Hydrocephalus with an incidence of 0.05%. Enlargement of the fetal abdomen. Ascites abdominal, neoplasm, other fetal masses, meningomyelocele, and cystosarcoma. Multifetal gestation. Multifetal gestation include twin pregnancy, triplets or quadruplets. Causes. Age. It's more common among women aged 20 to 39 years and dramatic decrease after this age occurs. Fertility drugs that stimulate the ovaries to produce many ovum. Multiparity. It is more common among parous women than nulliparous women. That's all. Thank you for watching.